And welcome to Talking Point. I'm Associate Professor Victoria Manning. I'm the Head of Research and Workforce Development here at Turning Point. And thanks for joining us today. Before we get started, I would like to acknowledge Indigenous Australians as the custodians of the land. Always was, always will be. For myself, here at Turning Point, I'm on the lands of the Wurundjeri people of the Kulin Nation, and I'd like to pay respect to elders past, present and emerging, and to acknowledge the important history, culture, strength, creativity, and achievements of Aboriginal and Torres Strait Islander people in Australian culture as we continue to work towards reconciliation. As I'm sure you're all aware, there is so much happening here in Victoria at the moment in response to the recommendations of the Royal Commission into Mental Health. And this presents an exciting opportunity to do so much better in supporting people with both mental health and alcohol and drug issues. So we're really fortunate today to have Dr. Jessie Young giving today's talk, which is titled Dual Diagnosis of Mental Illness and Substance Use Disorder, an underappreciated determinant of health disparities. We've been fortunate to have Jessie here before on our Talking Point programme, so I'm sure many of you will be familiar with him, and he's a fantastic programme of work. He's an NHMRC Emerging Leadership Fellow in the Centre for Health Equity at the University of Melbourne, specialising in psychiatric epidemiology with leading expertise in data linkage methodology. He's also a member of the Australian Institute for Health and Welfare's National Prisoner Health Information Committee and Technical Expert Group. And since 2014, he's authored over 100 scholarly works, including 61 peer-reviewed publications. His research has been cited in and informed national and international guidelines for the treatment of substance use disorders, the prevention of overdose, and access to health services for people released from prison, and as well as pandemic management and preparedness. In recognition of the quality and impact of his work, Dr. Young was conferred the 2020 Victorian Premier's Award for Health and Medical Research in Public Health Research. Congrats again, Jessie. So just before we move over to him, it's a quick reminder that this is a webinar, so please do put your questions into the Q&A function. And we should have around 10 or 15 minutes at the end of the talk to address as many of those as we can. The recording of today's talk will be available in about 2 weeks on the Turning Point website. So please do subscribe to the mailing list if you haven't already, and you'll get a notification of when they're available. And that will include some of Jessie's slides from today's presentation. Thanks very much, and over to you, Jessie.
Thanks very much, Vic, and welcome everyone. It's my pleasure to be here and get the opportunity to provide another talk in this fantastic forum. So I will try to keep as much time as I can and therefore preserve the 10 to 15 minutes of question time at the end so we can have a lively virtual discussion. So as Vic mentioned, my program of work has kind of focused in the later years on what we term to be dual diagnosis. So what I present here today is some of my recent work in the area, and also provide a bit of a historical perspective on how I got to this point. Just before I start, I'd like to acknowledge my grant and research support there, and also just mention that I have no actual or potential conflict of interest in relation to this presentation, apart from the funding sources mentioned above. So just a brief outline. I'm going to go into a little background about dual diagnosis and what it's associated with. And then I'm going to go into my program of work on the epidemiology of dual diagnosis, particularly starting, which was my early work in a very highly selected group, people who experience incarceration, and then looking more at my more recent work, looking at the population-wide studies or less selected studies, looking at dual diagnosis. I'm then going to go into a recent systematic review that me and my team were fortunate enough to conduct, looking at co-located care. So basically, one of the responses to dual diagnosis in this area. And then also, I'm going to give you a little overview of an upcoming study that I'm leading, looking at particularly at ADHD and substance use disorder. So I'm going to be channeling a bit of, throughout this presentation, a bit of Dr. Margaret Chan, who is the Director General of the World Health Organization. And she and I quote, stated, "Accountability means counting. What gets measured gets done." And I'm a firm believer in this statement. I think that in order to make progress, we need to measure things accurately and report them publicly, and then act on that publicly reported evidence. So jumping into dual diagnosis, so just a bit on nosology here. So what exactly is dual diagnosis? So it can be defined in many ways. However, I define it as concurrent mental illness and substance use disorder. And those, herein broadly defined according to the ICD-10 mental and behavioral disorder chapter. For those of you who are familiar with that, it's chapter F, and it has a number of subchapters. So below is the subchapters that I base this definition on. So mental illness includes F0 to F9, and then F20 to F99, and substance use disorder is subchapter F10 to F19. It is a very heterogeneous exposure by nature, because it does encompass numerous different flavors of mental illness and numerous different flavors of substance use disorder. So I just want to acknowledge that up front. But essentially what my thinking in this area and how I conduct my epidemiological research in this area is that it is a crude proxy for complexity. Okay, incorporating the co-occurrence of these two broad categories. So just a bit of background. So mental illness and substance use disorders in 2015, they were estimated to account for about 15% of the total burden of disease in Australia. It's the second leading cause of total burden of disease in this country, and the leading cause of non-fatal burden of disease in this country. These two things, so mental illness and substance use disorders, frequently co-occur and are strongly associated, whereby the presence of one increases the odds of developing the other. Population estimates of dual diagnosis in Australia are extremely scarce. In fact, I would venture to suggest that there's really only one reliable one in existence, and that's from the 2007 National Survey of Mental Health and Well-Being. And that estimate, they estimated that 2% of the general population annually has dual diagnosis. So that's the 12-month prevalence number there. Other studies have looked at the prevalence among people, say, seeking treatment for substance use disorder, and those prevalences are much higher. So you can see that a systematic review there estimated the prevalence between 47, or had a range of prevalences in studies of 47 to 100%. And other studies have found similar rates of substance use disorder among people seeking treatment for mental illness. So very common among those, if you have mental illness, it's very common that you may have a co-occurring substance use disorder and vice versa. So what do we know about the outcomes for people with dual diagnosis? Well, internationally, we know that dual diagnosis is associated with increased premature mortality. And what you can see here is a study, and you can see over here that the standardized mortality ratios for men and women are drastically increased for those who have co-occurring substance use disorders. And as you can see here, the mental illness, schizophrenia, bipolar, and unipolar depression. So if they just have those mental illnesses alone, you can see that the standardized mortality ratio is much reduced compared to those with dual diagnosis. And so that also stands when you compare it within, so relatively within those groups as well. So those with substance use disorder alone and mental illness alone have lower rates of mortality compared to those with dual diagnosis. Also, we know when we looked at other poor health outcomes, dual diagnosis is associated with increased suicidality, self-harm, interpersonal violence, overdose, chronic physical conditions, disability, reduced quality of life, and I could go on. So internationally, there's been some research to establish that, the health outcomes of people with dual diagnosis are very poor. And importantly, here's the rub. So, we see among people with dual diagnosis, there's higher levels of health service use overall. When we dive deeper, there's actually, it's primarily acute service in nature. So those, ED presentations or inpatient hospital admissions are increased. When we look at access to specialist care, we see that people with dual diagnosis have experienced barriers to accessing specialist care, such as, specialist mental health care or specialist alcohol and other drug treatment. And they report, people with dual diagnosis report that, they have increased unmet need compared to those who have single disorders alone. And for those who access care, so basically for people with dual diagnosis who access care, they're less likely to receive guideline concordant care when they do access it. And they report poor quality of care, which is very problematic and concerning. So just to belabor that point, if they have increased and more complex needs and they're receiving not only not concordant, guideline concordant care, but also poor quality of care, that is a substantial gap in their needs that are being met. So in 2015, there was a review published in Nature examining, challenges and opportunities for research in mental health and substance use disorders. And in that review, the authors highlighted that dual diagnosis is a key research gap in the domain of epidemiology. And they went on to suggest priority areas for looking at co-occurring mental illness and substance use disorders or dual diagnosis. What they highlighted, and there's many more, I just highlighted a few here: improve estimates of burden. They highlighted to identify synergies among co-occurring mental illness and substance use disorders, so how they interact. Understand vulnerabilities that impede access to care. So that's stemming off the last bit of evidence I provided. So to understand, those barriers to accessing care and also the care provided, and resolve these barriers to integrating mental health and alcohol and other treatments. So many things, and I'll go into this a bit later, but many recommendations have stated that we should integrate things like mental health care and alcohol and other drug treatment to achieve better outcomes and also reduce barriers. But anybody who works in the sector can probably attest to that there's certain barriers to integrating those two service systems in the first place. So they highlighted that as a priority for research to provide evidence on how to do that. So this really informed my program of work. I took a very keen interest in the interplay between mental illness and substance use disorder. And a lot of my program of work since has been focused on really these three things. So improving identification and access for people with mental illness and substance use disorders, achieve equity in that access and also the care provided, and really stemming off that focus on the quality of that care. So as stated before, I'm going to go into a little bit of the evidence that I've generated in a highly selected group. And for those who saw my previous talk or who know my research, I've spent a lot of my early career looking at the outcomes, the health outcomes for people who have experienced incarceration. So I'll just highlight a few things about highly selected groups. So as I said, I've done a lot of research in people with a history of incarceration. And here's an article that Stuart Kinner and I published in 2018. It's a pretty good quick overview if you want to read about the key elements or the key evidence in the area around people with a history of incarceration. Essentially, the potted summary is complex needs amongst this group are normative. Okay, so there's high rates of mental illness and substance use disorder. And this is all set against a backdrop of entrenched social and economic disadvantage. So the social determinants of this group are really, really important and rather poor. So one of the things that I was really interested in is, does dual diagnosis, given this high kind of bar of mental illness and substance use disorder, does dual diagnosis still make a difference when, you know, the kind of the floor effect may be apparent there? So it all started, I developed an algorithm to identify dual diagnosis from administrative data and prison health records. Identified basically 4 mutually exclusive groups. So in the left there, you can see the blue dots are people with no mental disorder. The red dots are substance use disorder only. The green dots are mental illness only. And the purple is dual diagnosis. This was in a cohort of about 1,325 individuals who were recently released from prison, and we followed them up for just around 2 years. And I was really interested in whether dual diagnosis is associated with non-fatal injury. And as you can see here, both in the left and the right graph, there's certain increased rates of injury among people with dual diagnosis. And not only that, the pattern of injury in terms of timing after release from prison changes. So what you can see is that there's a high burden of injury concentrated among people with dual diagnosis. This sparked a program of work amongst me and my team and amongst Dirk Kinner's group looking at dual diagnosis. So then we looked at non-fatal overdose after release from prison. And this is a piece of research led by a former student of ours, Claire Keane. And her work basically showed that dual diagnosis is the strongest predictor of non-fatal overdose after release from prison in this cohort. Here's a bit of research by Amanda Butler, who was a visiting scholar in our unit. And we basically looked at the predictors among of ED presentations among frequent attenders. And as you can see there, again, dual diagnosis is a very strong predictor of frequent attendance to the emergency department after release from prison. Here's a piece of research by another student in our group, Melissa Willoughby, who did a very interesting study looking at violence-related health contacts after release from prison. And again, as you can see here, dual diagnosis is a very strong predictor of violence-related health contacts. And here's a piece of research that I led. And concerningly, so what we did is we looked at, in the same cohort, we looked at people who presented to acute care for self-harm and then were discharged. And we followed these individuals up after discharge and looked at how many individuals got to ambulatory mental health care services after discharge for self-harm. The guideline here is that 100% of these individuals should receive mental health care within 7 days. We found that that wasn't the case. Only about 60% received any type of mental health care over the entire follow-up period, which was about 18 months. And concerningly, despite being at increased risk of suicide, people with dual diagnosis were about half as likely as those with no pre-existing mental disorder to receive mental health care. So again, that's the problem with access and barriers. There seems to be some barrier to accessing mental health care among people with dual diagnosis. And again, I've presented this before, but just to reiterate that we've also found that dual diagnosis is associated with increased health system expenditure, and disproportionately that health system expenditure is again through the acute care system. So emergency department and hospital costs are the predominant drivers of that healthcare expenditure. Okay, so that was a potted summary of the effect of dual diagnosis in a very selected group of individuals. So one thing that I was really interested in is, does that kind of association still hold when we move to a more unselected or population-wide sampling frame? So again, here's another study by Claire Keane, where we basically looked at over 900,000 residents in British Columbia, Canada, of aged 10 years and older. And what Claire did was first she looked at establishing through administrative records. So we had access to hospital and ED records and some other like primary care billing records to estimate the prevalence of dual diagnosis, because as I said, that population-wide prevalence estimates of dual diagnosis are really, really rare. And she estimated that the prevalence of dual diagnosis in British Columbia was about 1.7%. So that's pretty close to the 2% estimated in the 2007 National Mental Health and Wellbeing Survey in Australia. And then what Claire was interested in is looking at the association with overdose. So she looked at both non-fatal and fatal overdose. As you can see in this graph here, this is the cumulative incidence of overdose over time. And the dashed blue line here is people with dual diagnosis. The kind of purplish line here is substance use disorder only. And then you can see mental illness only in this dashed line here. And those with no mental health diagnoses are the solid blue line. So again, you can see that dual diagnosis really exerts an effect on overdose at a population level. Here's the adjusted and unadjusted hazard rates. So this is non-fatal overdose here. As you can see, the unadjusted effect is quite pronounced for dual diagnosis substance use disorder. When you adjust for these things, the dual diagnosis attenuates. So we adjusted for a whole bunch of socio-demographic and health characteristic variables, which would suggest that the social determinants of health for people with dual diagnosis are really important, because it does attenuate when you control for differences in that. Similarly with fatal overdose, again, the effect is quite dramatic. And when you adjust for those kind of socio-demographics and other characteristics, you start to see an attenuation there, whereby it's basically an equivalent effect for people with substance use disorder versus dual diagnosis. So stemming off some work that I did previously into self-harm among people who have been recently released from prison, we saw a very strong effect associated with dual diagnosis. One of the things my team got together, and this is a bit of research led by Kim Koop, who was a former student of mine. She did this for her master's thesis. We did a global systematic review on the prevalence of non-fatal self-harm among people with dual diagnosis. So, how common is it among people with dual diagnosis? We included both and defined self-harm as both with and without intent, suicidal intent. So that's basically non-fatal self-harm without suicidal intent, and then suicidal attempts. We compared the rates of those estimates to people with mental illness only or substance use only disorder only in the studies. We screened over 4,000 studies for eligibility we did in-depth full text review for 426, and we included 140 studies in the final paper. And as you can see, so we did a meta-analysis, and we came up with a pooled prevalence of for self-harm of 44%. So people with dual diagnosis in the study had a 44% of people with dual diagnosis reported some history of self-harm, and that was compared to 23% among people who only had a diagnosis of mental illness. And 27% of those with only diagnosis of substance use disorder in those studies. So as you can see, markedly increased among people with dual diagnosis. And that was just for self-harm without suicidal intent. And then when we looked at those studies who had looked at suicide attempts, we found a prevalence of history of suicide attempt at 39% among people with dual diagnosis, compared to 27% in those with mental illness only, and 18% in those with substance use disorder only. And as you can see, Kim's quite an intrepid researcher. There is a lot of studies that she went through for this particular estimate. You can see on the right there, that's the forest plot. I've been really fortunate to be part of another bit of research with Lisa Sharwood in New South Wales at the Black Dog Institute. We've been really interested in how individuals recover from injury and how pre-existing mental disorders may affect recovery or the trajectory of recovery after injury. So here's a bit of research that we did a couple of years ago, looking at pre-existing dual diagnosis and among those people who have had a traumatic spinal injury. So what we did is basically we looked at approximately 13,500 individuals hospitalized for traumatic spinal injury. And then we looked at their health records prior to that and identified, again, this mutually exclusive pre-existing mental disorder status variable, which included, those who had no mental disorder, those who had a mental illness alone in the records, those who had substance use disorder alone, or those who had the concurrence of both of them, which is the dual diagnosis group. And again, as you can see, quite a marked effect. So this is the association between dual diagnosis and length of hospital stay after traumatic spinal injury. So two conclusions from this, and we found that the injury, the traumatic spinal injury was actually more severe on average for people with dual diagnosis. And also there was indications that the recovery was also more challenging. So we found increased acute care costs, almost double compared to those with mental disorder when you account for covariate factors. And we also found a fairly high rate of hospital-acquired complications. We found, and concerningly, again, thinking about that integrated care recommendation, we found that there was very low rate of individuals who, during their recovery, got access to psychology and social worker consultation. So not only was the injury more severe, they were less likely to get, again, that kind of guideline concordant care for their mental health. And then more recently, Lisa and I are leading a piece of research in a larger sample of individuals, who experienced traumatic spinal injury. We're looking at all-cause mortality after traumatic spinal injury. And again, looking at if dual diagnosis, if pre-existing dual diagnosis affects that. And as you can see here up in the top right-hand corner, here's the survival curve. The dual diagnosis is in the yellow. You got green with a mental illness alone group, and the substance use disorder alone group is in the red. And then you've got the comparison of people with no evidence of pre-existing mental disorder there in the blue. As you can see again, and we split this into 2 age cohorts, so people who were age 15 to 64 at their presentation for traumatic spinal injury, and those who were 65 years plus. Just because traumatic spinal injury is common in people of quite advanced age, and so we wanted to look at whether those kind of end of life effects may be masking some of the dual diagnosis effect, just because of the high rate of mortality from all causes at end of life. And as you can see down here in the left, if you look, the association between substance use disorder and dual diagnosis is quite profound in the younger age groups, and it attenuates a little bit among the 65 plus group, and mental illness seems to take on a bit of a more prominent role among the 65 plus group. And that's primarily due to what the ICD-10 terms organic mental disorders. That would be your dementia and Alzheimer's and things like that. We went one step further and compared this to the general, the expected general population mortality rates. And we adjusted for age and sex doing that, and indirectly standardized. So among, our sample was 17,636 individuals with traumatic spinal injury. And as you can see here, again, it's even more marked, the association with dual diagnosis. So the general trend is, as you move up in complexity, as I mentioned, dual diagnosis is kind of this proxy for complexity, mental health complexity. You see that this standardized mortality ratio increases on average, and very markedly so for the people aged 15 to 64 years. As you can see here, you've got a standardized mortality ratio of about 17 for that group. So, and just for context, standardized mortality ratios for people recovering from traumatic spinal injury are typically internationally between 1.7 and 1.9. And that's what I've estimated among the no mental disorder here. And so you can see there's quite a profound effect on mortality if you have a pre-existing dual diagnosis. Here's another piece of research that I've been a part of, and this is just a quick. So Josh Knight and James Fold and others led this piece of research, and basically what we did is we developed an online version of what's called a harvest plot, and the harvest plot, as you can see right here, this is the non-interactive version. But what it allows us to look at quickly is to look across studies. You can basically see two things: the general association, so what direction the association of the study finds, and also you can look at what the quality of the studies are that find that outcome. So null would mean there's no difference in terms of time here. If we look at time to relapse or readmission, this is the effect of personality disorders on alcohol treatment, essentially. So people with personality disorders have a shorter time to relapse or readmission in 4 out of 5 studies that investigated. And if you look at the quality, which is the height of the bars, you can also see that the higher quality studies tended to find a poorer result for people with personality disorders. The other thing of note here is also treatment retention. So Obviously, this goes hand in hand with time to relapse, but the treatment retention was also similarly affected, although, there's more studies that found a null effect. But if you see here, the higher quality studies tended to find that personality disorder impacted treatment retention in a negative fashion. So I've got a link down here to the interactive harvest plot, where you can look at different methodological parameters of the studies and look how that affects these associations. But I guess the take-home message here from the systematic review is that particularly on treatment retention and time to relapse to substance use disorder, the co-occurring personality disorder impacts that quite greatly. So moving on now to what are the proposed solutions in this area for people with dual diagnosis? Well, the main solution often purported in terms of treatment provision sense is that we need to provide integrated treatment. So there's been a historical separation, at least in Western countries, between mental health care and alcohol and other drug service systems. And if you're an individual with dual diagnosis, this often would necessitate navigation between two poorly coordinated systems to get your needs in both areas met. I would suggest that this is an avoidable structural barrier to continuity of care for these individuals. And there is some evidence that only 7% of those with dual diagnosis receive treatment for both mental illness and substance use disorder annually. That evidence is from the United States. So not good enough. Most guidelines for the management of dual diagnosis now recommend what is termed these integrated models of mental health care and AOD treatment. If you look at the Royal Commission of Victoria's mental health system, these have been reiterated in recommendations 35 and 36. These models include varying levels of 3 elements usually, one of which is care coordination, another of which is service integration and physical co-location of these services. So I was very interested in the physical co-location of services as this removes the traditional structural barriers to receiving this integrated treatment. And when I looked at the current literature, I noticed that the independent effect of co-located care on health outcomes has not been synthesized. So me and my team, and I'd like to acknowledge Claire Glover-Wright, Kim Koop, and Alex Campbell specifically for their tireless work on this. We conducted a global systematic review. Our population of interest in this review was people with dual diagnosis. The intervention or exposure that we were interested in is outpatient mental health specialist care co-located in AOD treatment, or vice versa. So that would be AOD treatment specialist co-located in mental health care settings, or a dedicated dual diagnosis service with both mental health care and AOD specialists involved. Our comparison was, conditions of no care or conditions of care but not co-located mental health and AOD care. So you just had a parallel referral system, or basically just the provision of one of those 2 elements of care. Our outcomes that we were interested in, so we were interested in treatment, engagement, and substance use outcomes. Things like remission, abstinence, and the rates of treatment retention. We were also interested in physical and mental health outcomes, so whether it be symptoms, rates of morbidity, mortality, that kind of thing. Thirdly, we were interested in other health service use patterns, so primary care, acute care, et cetera. And we were interested in whether there was a research on health economic outcomes, so total costs or formal cost effectiveness studies. So we screened 5,800 abstracts. We reviewed 241 full texts for eligibility, and we ended up including 23 articles from that review, and then an additional 3 articles were identified through what's called citation and reference chaining. So what did we find? Well, we conducted a qualitative synthesis, and we had 26 included studies. All of those studies were conducted in the United States. There was 9 randomized control trials, 2 non-randomized trials, and 15 cohort studies. The sample size were rather modest, so ranged from 28 to 3,500 at the top, and 21 of 26 studies investigated co-located multidisciplinary teams, so that extended beyond just mental health care and alcohol and other drug treatment professionals. 2 of 26 investigated a dedicated dual diagnosis service with both, psychiatric or mental health care and alcohol and other drug treatment specialists involved. And 3 investigated embedding, like I mentioned before, the mental health or AOD specialist in existing either mental health or AOD services. So in terms of treatment engagement and substance use outcomes, 22 out of the 26 studies quantified the relationship between co-located care and treatment engagement or substance use outcomes. 6 had reported a positive association between those things. 9 studies found a correlation between co-located care and reductions in substance use patterns, and 7 studies found a positive correlation with abstinence or remission from substance. All other studies, so those aren't mutually exclusive. Some studies can have overlap and investigate multiple outcomes. So there was quite a few studies that either found a null finding, and there was a few studies, it wasn't completely equivocal. There's few studies that found, the opposite effect. 16 of 26 studies investigate the relationship with at least one health outcome, and 9 observed significant improvements in mental health symptom severity. So that was by far the most common of the health outcomes investigated, so mental health symptom severity. 5 reported improvement, general quality of life, and 1 reported no reduction in suicide attempts. So really the suicide attempt study was one of the only study that investigated kind of behaviors or morbidity. There was no studies that looked at mortality, so fairly limited in the health outcomes domain. And when we looked at health service use, 11 of the 26 studies investigated the relationship with at least one health service use outcome. 8 studies reported decreases in hospital admissions and/or hospital length of stay. 3 reported decreased rates of ED presentations. 2 reported on patterns of outpatient service use, primarily mental health service, so ambulatory or community mental health service use. And they reported mixed findings. 1 of them reported that the outpatient service use increased, and 1 reported the opposite effect. 1 study reported decreased mental health and AOD inpatient stays, however. When we looked at health economic outcomes, even more limited. So 4 out of the 26 studies investigated some kind of health economic outcome. All of those studies, however, that looked at health economic outcomes reported significant total cost savings associated with co-located care. Most of these cost savings were attributable to lower rates of acute care use, and all costing was restricted to the health system in these studies, and there was no formal cost effectiveness studies. So we then endeavored to look at the quality assessment, or what more accurately would be termed risk of bias assessment. So we assessed that with the master scale, which basically looks at 40 safeguards against bias present in the studies or absent in the studies. The proportion of bias safeguards present on average, the median was 58% of the 40 across all studies, and only 12 of the 26 studies scored above the median. Relatively low quality overall, we would suggest. So I stress that, in the previous findings, I stress caution when interpreting those findings. For example, of the 10 studies that found a positive association with ED or hospital use patterns, 3 had a low risk of bias. So, you only have 3 out of 10 of those studies that would be considered to be high quality. So what conclusions can we draw? Despite 2 decades of recommendations to implement integrated or co-located care, there's a lack of high quality evidence on these outcomes, particularly the outcomes these models aims to achieve for people with dual diagnosis. And there was no studies in this global systematic review from Australia. So when we talk about implementing these things in Australia, at least from a peer-reviewed evidence point of view, we have very little to go on. We had some limitations in our review, so we could not disaggregate the effects of care coordination, service integration, and co-location. So basically, we were limited by what was described in the studies and how the evidence was generated. So we can't categorically conclude that the effects reported were simply due to physical co-location of these services. It could be a combination of care coordination, service integration, et cetera. So really, this gives us a limited understanding of the independent effect of co-location, which is problematic because we don't know what works and why. On the basis of the available evidence, one conclusion we could suggest would be that co-location and integration of mental health and AOD specialist care is likely to yield health and economic benefits. However, as I said, there's some caveats to that conclusion. Now I just want to present a stream of research and an exciting cohort study that I'm leading in the area of basically ADHD among people who seek treatment for substance use disorders. So this is a very special flavor of, or a very particular flavor of dual diagnosis. So I've done some work in this area since 2013. And what we know is that approximately 1 in 4 people with substance use disorder have a co-occurring ADHD. And ADHD, co-occurring ADHD complicates the clinical profile and treatment of substance use disorder. It's associated with poor physical and mental health outcomes, reduced quality of life, suicidal behavior, and premature mortality, to name a few. What we know of ADHD and alcohol and drug and other drug treatment settings is that it's not systematically identified currently. And this, systematically identifying ADHD or co-occurring ADHD is a prerequisite for initiating appropriate treatment. Clinicians are brilliant at, at acting on information they have. They're very terrible at acting on information they don't have. So without, identifying this issue, the treatment therefore does not flow. But also when you take a broader perspective, and this is something that that myself and others recently published in the Australian and New Zealand Journal of Psychiatry, it's also critical for health system change. So, again, this is the Margaret Chan channeling this idea about, what gets measured gets done. Measuring the co-occurrence of this thing of ADHD in these settings is important for workplace development, achieving value for money and value for investment, and also is critical to stakeholder and policymaker engagement. So back in 2014, I led a study looking at, and this was one of the first of its kind in Australia, looking at both the prevalence and association of co-occurring ADHD and association with, chronicity of substance use disorder. And what we found is we screened a whole bunch of adults as they came into alcohol and other drug treatment. And we found that about 44% of those individuals screened positive for co-occurring ADHD, whether that be clinical or subclinical levels. And that was associated with increased chronicity of amphetamine use disorder, benzodiazepine use disorder, and alcohol use disorder. Follow-up work by Charlene Kay and others found that co-occurring ADHD was also associated with driving-related risk-taking, driving offenses, and driving convictions, and driving while currently disqualified. So the increased risk-taking in the driving domain. This is just some of the evidence that we've generated along the way, and this work has led to a recent flurry of recommendations for both adults and adolescents who present to substance use treatment with ADHD. So these recommendations, as you can see, was part of a consensus statement recently. And basically what the key take-home messages from that was that systematic identification of ADHD in AOD settings is crucial. Once you identify, initiate treatment and interventions early in their treatment life cycle, and then make sure that treatment is not predicated on abstinence from substance use, although abstinence may be the ultimate goal. However, despite these international guidelines, ADHD remains one of the most misunderstood and stigmatized and undertreated mental disorders in adults seeking treatment for substance use disorder in Australia. So I've endeavored to lead the Australian arm of the INCAS study. It's a multinational prospective cohort study of people seeking outpatient treatment for substance use disorder with co-occurring ADHD. It's a survey and clinical record design, clinical record extraction design, sorry. It's occurring currently in 23 sites across 8 countries. There's screening and then clinical diagnosis of ADHD. One of the limitations is there's no comparison group. So what we're aiming to do is add a comparison group in the Australian arm of the INCAS study, and also complement that initial design, which you'll see here on the left. This is what the international study looks like, with a comparison group, and add linked administrative data, because we have that capacity in Australia. So we'll be able to follow these individuals up 3.5 years prospectively, looking at more hospital records, ED records, death records, pharmaceutical dispensing records, and also Medicare records. We'll also have 1 year retrospectively, so we'll be able to look back in their record history prior to engagement with the service. Here are the aims of the study. I won't go into them in detail, but we want to look at the prevalence of ADHD. Again, following that review, look at the excess health burden attributable to co-occurring substance use disorder and ADHD. Look at the type and length of treatments provided, and determine which types and patterns of this treatment reduce acute care contacts, increase primary care use, et cetera. And we also want to quantify the costs. we're also just briefly, I know I'm out of time, but just briefly, we're going to also engage in a targeted translation campaign and also use a Delphi consensus study to bring back in the practice-based evidence to our findings. Thanks for your time. Question?
Fantastic. Thank you so much, Jesse. I mean, it's just, I've said this before, it's such an impressive body of work. It really, really is. Such powerful data, such alarming data. But yeah, I mean, it's just fantastic. And I really was so impressed by your systematic review of exactly what we need right now, particularly in Victoria, of looking at the different models of integrated care. We've got a couple of minutes for questions, so I'll just, there were a couple in the Q&A around really noting that so much of what you presented is based on the US literature. Can you speak to why is it that we don't have much elsewhere in the world in terms of quality RCTs? Can you speak a little more to that?
Oh, that's a difficult question to answer, really. I mean, I think sometimes there's a reliance on some of those US RCTs among academics and other evaluators to say, oh well, we've already, this has already been done, so we don't need to do it here. The problem with that thinking, from my perspective, is that we have a very different health system. We have very different cost drivers. We have very different, safety nets. We have very different funding. Public funding versus private funding is very different in Australia compared to the US, and so I don't know why this hasn't been evaluated. Maybe it has been evaluated and just not published in Australia in a peer-reviewed sense. That could be the case too, because we didn't include a gray literature search in the area. But it's a bit concerning from my perspective, because we have all these recommendations that now the government has said that they're going to implement, and essentially, from a high quality evidence perspective, we don't have much to underpin those particular recommendations I highlighted, and that is a bit of concern from my perspective, because the amount of money that is being quickly diverted into this endeavor could be misspent very easily if we don't get it right.
Yeah, exactly. It really needs to be based on the local context. It also relates to other questions around, I guess, models of care. And there's perhaps even an opportunity to address this gap. Somebody's asked if you would be interested in evaluating a model of care in EDs, which is soon to be implemented, that co-locates and integrates and coordinates assessment for people with co-occurring issues. So maybe we can start to address that gap.
The answer would be yes. I'm always interested in robustly evaluating healthcare intervention. The caveat there is that I'll only evaluate it if I can publish it in a peer-reviewed or public sense.
Yeah. But I think it's a really important point you make, Jesse. I mean, you spoke in the beginning about the fact that we're still using data from 2007, the most recent national survey on mental health and well-being, for these estimates on the prevalence of not just co-occurring disorders, but also substance use disorders often. So there really needs to be, new data and also evaluations of how these services achieve the desirable outcomes or desired outcomes, here in Australia. I think it's a really good point that you've made.
Sorry, Vic, and just briefly, I think that's really important from a resourcing standpoint. If we're basing our resourcing, for the AOD treatment sector on an estimate from 2007, that estimate could be fairly off by now, or the patterns of substance use could change dramatically over, what would that be, like 14 years. That has implications for actually resourcing the entire sector, let alone just the local context.
Absolutely. Well, we're at time, unfortunately, but please do reach out to Jesse. His email is is there. And so, yeah, I just want to thank you again. It's been a fascinating talking point today. Really, it's always a pleasure to have you here, and hope to have you again. And have a great day, everybody. Thanks for joining us. Oh, I should just say next month, is actually Turning Point's very own AOD Stats. It's a talk around the redevelopment and the relaunch of a community tool to map alcohol and drug harms across Australia. So if you're keen to find out the new features and how you can use that in your work, please join us on the 15th of December next month. Thanks very much and have a great day.
Thanks, everybody.